So this is my motor speech disorders evaluation. You want to look at your patient's mouth and is their mouth symmetrical? And can you force the lips open with your fingers like this? This tells you if there's any weakness or paralysis of the lower face. Weakness can be indicative of a flaccid dysarthria, and weakness coupled with spasticity can indicate that there's a spastic dysarthria. Is their face expressionless or mask-like? This is common in people with Parkinson's disease. People with Parkinson's may display difficulty in showing emotion with their facial expressions, and their reduction of dopamine in the basal ganglia causes a hypokinetic dysarthria. Is there wrinkling on both halves of their forehead? So this is to see if there's any neurologic damage. Let's say there's damage to the right of cranial nerve 7 where it comes out of the brain stem. This will present the whole right half of the affected side of the face displaying paralysis or weakness. Then, when the patient looks up to the ceiling, the muscles on the affected side won't contract as they should, making that side appear smoother. And it's also possible for someone to have neurologic damage and have the ability to wrinkle the whole forehead. So that damage will be occurring in the right or left tract of the upper motor neurons. So you want to have your patient smile and pucker their lips. This is checking for weakness, range of motion, and voluntary movement of the lower facial muscles. And if there's groping when attempting to do voluntary movements, it's possible that the patient has nonverbal oral apraxia. Can the patient puff out their cheeks? And so you're checking the strength of the lips and the velum. If there's reduced strength in the lips, air will leak out. If there's weakness in the velopharyngeal port, air will come out of the nose. Does the jaw hang loosely or deviate to one side when the mouth is open? If it does, there's bilateral damage to cranial nerve 5. Bilateral damage doesn't usually happen, but usually only one side is affected, but the muscles on the unaffected side are still strong enough to hold the jaw in place. Can the patient move the jaw to the left and right? If the patient can't do this, it suggests that there's bilateral weakness in the jaw muscles, and if groping's present, there might be a nonverbal oral apraxia. Can the patient keep the jaw closed when the examiner tries to open it? And can the patient keep the jaw open when the examiner tries to close it? If the patient can't provide strength upon resistance, this is indicative of a bilateral weakness of the jaw muscles, which can mean there may be damage to the trigeminal nerve or cranial nerve 5. Does the tongue look normal at rest? Does it look atrophied? Is it symmetrical at rest? The tongue will be smaller and look atrophied if there's damage to the lower motor neurons. If the tongue looks atrophied on one side, there may be damage to the hypoglossal nerve. If the tongue is atrophied on both sides, there's damage to the right and left hypoglossal nerves. So to do this, you just have them open their mouth and you just look at their tongue. And while you're looking at the tongue, is the tongue still at rest? If there are fasciculations present, it might be indicative of a lower motor neuron damage of the hypoglossal nerve. Can the patient completely protrude the tongue? This looks at the range of motion of the posterior fibers of the genioglossus muscle and the transverse intrinsic muscles. The tongue can be only partially protruded at most if there's bilateral weakness, and if only one side is affected, the tongue will deviate to the affected side. Can the patient keep the tongue at midline when the examiner tries to move it left or right? Again, this is testing tongue strength. And can the patient touch the tongue to the upper lip? This is assessing the tongue muscles that protrude and elevate the tongue. Can the patient keep the tongue pressed against the inside of the cheek when the clinician pushes the cheek inward? This is testing the tongue strength of several tongue muscles, but mostly the longitudinal muscles. Can the patient move the tongue from side to side? This is testing the range of the superior and inferior longitudinal muscles, which move the tongue laterally. Decreased lateral movement will indicate any unilateral weakness of the muscles. Does the velum rise symmetrically when saying ah, 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 ah? The entire velum should be raising while the back of the upper pharynx should move inward to meet the velum. If there's any unilateral weakness, the affected side will show decreased movement or no movement at all. The uvula will be pulled toward the unaffected side. Can the patient produce a sharp cough or a glottal stop, like or This assesses the vocal folds' adduction abilities. The ability to produce a sharp cough and glottal stop tells you that their vocal folds are closing tightly and they have adequate subglottic pressure. Is inhalatory stridor present? If this is present, it tells you that the vocal folds are not closing properly, and this can be a result of abductor muscle paralysis, which can indicate unilateral or bilateral damage to the vagus nerve. Take a deep breath and say ah for as long as you can. Ah. You want to do this, you want to see if they can do this for about 15 seconds. This looks at breath support and vocal fold adduction. Presence of hypernasality, breathiness, harsh vocal quality, and diplophonia can be symptoms of various pathologies. A low pitch can be indicative of a spastic or hyperkinetic dysarthria. Pitch breaks can mean there's a spastic or flaccid dysarthria. Excessive variations in loudness can mean there's a hyperkinetic dysarthria. Decreased loudness can be indicative of a flaccid or hypokinetic dysarthria. So you want to ask the patient, take a deep breath and say ooh for as long as you can. If someone can adequately say ooh, this means they have complete velopharyngeal closure. If there's air coming from the nose, the velopharyngeal port is not adequately closed. Then you want to have your patient say ooh while you squeeze and let go of their nose like this. Ooh. Now you'll see that there's no change in my resonance, but this is another way of assessing velopharyngeal closure. There will be a change in resonance when closing the nose and opening back up if there's inadequate velopharyngeal closure. Say pa, 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 pa as long, fast, and easily as you can. People usually have slow and regular alternate motion rates with spastic and flaccid dysarthria. People tend to have slow and irregular AMRs if they have ataxic and hyperkinetic dysarthria, and people who have hypokinetic dysarthria can display a more rapid AMR. This can make their articulation of phonemes unclear. Say pataka, pataka, pataka. Sequential motion rate tasks are done because they require more work for the articulators. It's possible for people with dysarthrias to successfully complete the AMR task, but their deficits come out more in SMR tasks.